respected participants, dear panelists, dear colleagues, and my respected panelist, Dr. Anil Saxena. Good afternoon. Also, Professor Rajendra sir, Professor Wadud sir, Anil sir, everybody welcome. Also, Devasrita Bhattacharya from the St. Jude's Medical Laboratory, welcome you all. Dr. Anil Saxena is an internationally acknowledged expert in the field of cardiac arrhythmias and electrophysiology. Since joining Fortis in 1989, Dr. Saxena has been actively involved in setting up Department of Cardiac Electrophysiology. He is one of the pioneers in the introduction of ICD and biventricular pacemaker in India. He has largest experience in the field. He has been performing electrophysiology study and radiofrequency ablation for the various complex cardiac arrhythmia for over 25 years. IPDI are delighted and honored sir with us, and he is the best person to talk about the pacemaker. Welcome, sir. Professor Abdul, sir, please give some comments on this class. Sir, sir.
Yeah, hi. Can I share my slides now? Okay. Good afternoon, everybody. It's indeed a pleasure to be here in this wonderful symposium. And can you see my slides?
Yes, sir.
Yes, sir, we can see, sir.
Yes, sir.
Okay. Just a moment. Which one? I hope I am sharing the correct slides. Yeah, can you see my slides?
Yes, sir.
Okay.
Yes, sir. Now it is full screen, sir.
Now it's full screen.
Yes, sir.
So good afternoon, everybody, and I must thank all of you, and especially Dr. Mohsin, Dr. Chowdhury, Dr. Majumdar, Dr. Adhar Ali for having me here. And I hope all of you and all your friends and families, everybody is safe in this difficult time. So today I will discuss the basics of pacing. I have kept this talk especially simple, as Dr. Mohsin had advised me, for the benefit of postgraduates, to discuss right from the ABC of pacemakers. So pacemakers, as we all know, they are electronic devices which control the heart rate, and they can provide energy for sending electrical impulses to the heart to improve the heart rate whenever the patients have bradycardia. And as we can see in this picture, they have a circuitry to control the pacing functions, and they have a battery to provide the energy, and of course they are connected to the heart with. Can everybody be?
Sir, unmute please.
And they have pacing leads to deliver current to the myocardium.
Thank you, sir.
So that and they can also sense the native electrograms. Now, the evolution of pacing therapy has taken a lot of time. The first pacemakers were implanted in 1960, around that. And so it has been like about a 60-year journey. And initially, when pacemakers were invented, it was mainly to prevent death, because patients with complete heart block used to die. So the initial objective was just to reduce morbidity and risk of death. But subsequently, the quality of life and functional capacity was also improved. That became one of the objectives. And then they developed the rate responsive, this technology where the pacemakers were able to sense the body activity and increase the heart rate increase during exercise. And after that, further advancements took place, and now we have for last many decades we have dual chamber pacemakers which provide AV synchrony, which is the natural way how the heart functions. And also after that there was development of rate adaptive AV delay, which optimizes the AV delay as happens naturally. Whenever we exercise, our heart rate increases, there is a shortening of PR interval. The same thing is adopted in the pacemakers as well. With further development came cardiac resynchronization therapy or biventricular pacing, because it was realized that in many patients, especially those with LV dysfunction, if you pace only on the right side of heart, that is right ventricle, there is dyssynchrony within the ventricle, and that further impairs cardiac function, and patients have worsening of heart failure. So synchronization of depolarization was achieved by ventricular pacing or CRT. And more recently, we have what we call his bundle or left bundle branch pacing, which is also called conduction system pacing, where without the second lead, we can achieve cardiac resynchronization with one lead only. And of course, we have development of leadless pacemakers also, because it was thought that pacemaker leads are the weakest link, and sometimes they can fail, and then extraction becomes difficult. And also they are subject to infections, lead endocarditis, etc. So leadless pacemakers, they obviate, they prevent the need for pacing leads, and they can be implanted in the right ventricle, and they can provide pacing. I will not detail about the history much, but you can see how big the pacemakers used to be before the implantable pacemakers came. Patient had to carry the pacemaker himself. And this is the first variable battery operated external pacemaker. That was 1957. And as I said, in 1960, first implantable pacemaker was given to a patient. And now we have, of course, come very far, and we have very small pacemakers with very long-lasting leads, and MRI compatibility is now standard in most of the manufacturers. Now they don't even sell non-MRI compatible pacemakers. So we have come a long way. Along the way, what happened was there were some common standards which were developed, and the most important one were related to the lead, so that each manufacturer's leads became compatible with the other manufacturers. So in this regard, this is a very important development called IS-1 standard for leads. And then we have IS-4 standard for quadripolar, and DF-4 for the defibrillator leads. But for the pacemakers, a vast majority, we have this IS-1 standard, which can be so that every manufacturer's lead is compatible with other manufacturers' leads. And as we can see in this picture, in the left panel, we have the pacemaker battery, we have the electronics, and we have this header, which has two receptacles in this case, because it's a dual chamber pacemaker, and the lead can be inserted in each of these. This IS-1 standard lead, as we can see printed here, and it has to be screwed. The shell of the device usually is titanium shell, which provides a hermetic sealing so that no body fluid can enter the device. It's very light, strong, and non-allergenic. So that has become a titanium alloy has become the standard for these devices. As far as the battery is concerned, most of the batteries are based on lithium, lithium vanadium, lithium iodine, and so many other compounds of lithium. And which is very long lasting. It has a very good shelf life. It doesn't bleed the charge itself. Another important component is the reed switch, which gets activated when we place the magnet over the pacemaker. So the pacemaker becomes asynchronous when we place a magnet over the pacemaker. That is, it stops sensing. So that has some utility in certain situations, which we will discuss in the troubleshooting. But right now, this is one of the basic components of pacemakers, which is called reed switch, which is present inside and which gets activated when we place a magnet over the pacemaker, and it stops sensing. Now, as far as the leads are concerned, they can be endocardial or transvenous leads, which are placed via the subclavian or axillary, or rarely by the femoral vein, or they could be myocardial or epicardial leads. And they can be passive fixation, which have tines. This is the lead which was more often used, or the only they are available in the past usually. But more often people are switching to the screw-in leads, which have an extendable screw, which can be screwed into the endocardial tissue. And the advantage is that the dislocation rate of this lead is much less compared to the other lead, which is tined lead. The one disadvantage in the initial experience was that of perforation, because this lead is more susceptible to cause perforation. But that problem has been taken care of, because we now know that it can happen. So most of the operators are very careful, and generally when we screw, we do not extend the stylet right up to the tip. So we know how to take care of the problem of perforation. One advantage of this development has been that we can place the lead anywhere in the cardiac chamber. So usually nowadays we don't like doing RV apical pacing much because that produces more dysynchrony, and more often than not we now do the mid-septal pacing, which produces a relatively narrow QRS complex. And as it's quite obvious that we cannot put the tined lead at the septum because it will fall. So we have to have an active fixation lead there. Then there are other leads which are epicardial stab-in or screw-in leads or suture-on leads, which are placed on the epicardial surface. Sometimes we have both the veins not available, and or sometimes after surgery, in pediatric especially, the pacemaker is implanted, and surgeons can directly implant these leads, fix these leads over the surface of heart. So these are called epicardial leads, which are sometimes needed in many patients. More recently, there is in some adaptation, increasing adaptation of his bundle pacing or conduction system pacing. It is still in the early stages of adoption. Even in the United States, like maybe less than 5% or less than 10% pacing is happening through left bundle or his bundle pacing. But this is something that we are increasingly looking at, and maybe in future it will become the norm. It's not a very new thing. It has been there for 20, 30 years. In between, it had been almost given up. But of late, there is a renewed interest in the conduction system pacing because it can be especially helpful in patients who have LV dysfunction. It can prevent further deterioration of the LV dysfunction. In patients who have a normal left ventricular function, the advantage may be very marginal. Now, coming to the type of leads, we have unipolar leads and bipolar leads. Of course, yeah, one thing I forgot to tell, that there is a leadless pacemaker now, which can be implanted transvenously just in the right ventricle, in the lower septum. It's a percutaneous procedure. The hardware is very less. You can see the pacemaker just in the right ventricle. It has very few complications, invisible to the patient. It doesn't require any pocket formation, so the complications related to the pocket are not there. And overall, the longevity is now comparable or almost comparable to the other pacemakers. So the new models, they have a 8 to 10 years longevity. And now we have a AV synchronous pacemaker also available, which is leadless. So this is also a good development, which may become popular over next few years. One disadvantage of the leadless system is that it's very difficult to retrieve once you implant it. So if patient is young, patient may end up having many pacemakers in the right ventricle. So it's very useful for elderly patients who need maybe one, maybe two pacemakers, because we cannot take out the pacemaker. We have to implant a new pacemaker. Time comes, at least the technology right now doesn't exist. Now, let us discuss about the single and dual chamber pacemakers. So all pacemakers and also ICDs, they can be single chamber, they can be dual chamber, or they can be biventricular. As I said earlier, that in CRT, we implant a biventricular pacemaker where we put one lead in the right atrium, one in the right ventricle, and one in the coronary sinus vein to pace the lateral wall of the left ventricle. But most patients receive either a single chamber pacemaker or a dual chamber pacemaker. So what's a single chamber pacemaker? In single chamber pacemaker, the pacemaker, of course, is implanted in the usual manner, but we have only one lead, which is placed either in the atrium, when it will be called atrial pacemaker, or in the ventricle. In this picture, it is shown in the ventricle at the RV apex. So it's a single chamber ventricular pacemaker. And the way to recognize is that this is a AAI or atrial pacemaker, where we can see that in the first few beats, the pacemaker is pacing at a certain rate. It's I think around 60, and then the atrial rate increases and the patient has a spontaneous. So In this, we can say it is probably a atrial pacemaker, although it can be a DDD also. Now here it becomes quite obvious that this is a ventricular pacing, because we can see the pacemaker spike, and then we can see the white QRS complex, which is a paced complex. And the pacemaker can sense a spontaneous beat. So the third beat is spontaneous. We can see on the marker channel it is written VS, that is ventricular sense. And then after the escape interval, again, if there is no spontaneous beat, then the pacemaker again gives an impulse and the patient has a paced QRS complex. So this interval from the sensed beat to the first pace beat is called the escape interval, and the interval between the two pacing beats is called pacing interval. And this is a classical example of VVI pacing at the rate of 60. A dual chamber pacemaker system has two leads, one implanted in the atrium, as we can see in this picture on the right side. One lead is in the atrium and one lead is in the ventricle. So it's a dual chamber system, and they can function in one of the two ways, one of the four ways rather. So you can have atrial sensing, ventricular pacing, that is in the top strip. You can have atrial sensing and atrial pacing and ventricular pacing. So both chambers are pacing in the second strip. In the third, we have atrial pacing but ventricular sensing, because the AV conduction in this example seems to be intact. And in the fourth, the pacemaker is in standby. There are many patients who have an intermittent problem. So, and for those, they may have either sinus pauses or whether they have intermittent complete heart block. But when they have a normal rhythm, at that time, the pacemaker will be in complete standby, and we may have A sense and V sense. And that's how the ECGs of these four types of dual chamber pacemaker operation will look like. In the top left, we have both the chambers pacing. So we have A pace, V pace. Then we may have A sense, V pace. In the third, we may have A pace, V sense. And the fourth, we may have A sense, V sense. So that's how it looks like. Now, the advantages and disadvantages of single chamber pacing system should be understood. The advantage is that we need to implant only a single lead. And of course, the second advantage is that the cost is significantly less as compared to a dual chamber pacemaker. But the disadvantages are that a single chamber pacemaker does not, if it is in the ventricle, then it doesn't provide AV synchrony. And so therefore in complete heart block, we have to provide in the ventricle only. And obviously it will not give AV synchrony in that case. And if we implant only in the atrium, like for example, if patient has a sixth sinus syndrome, and we give the patient a AAI pacemaker with only one lead in the atrium, then it will not provide ventricular backup if the patient develops AV block. So there are disadvantages of single chamber as well, but in some cases it can still be implanted. Now, we all must know that there is a pacing system code which has been developed by the National British Group, so which basically means that there are 5 letters in that code. Letter 1 represents the chamber pace, so it could be V, that means ventricle, it could be A, that means atrium, D means dual, O means none, and S means single. The second letter indicates the chamber that is being sensed, so it could be ventricle, atrium, dual, again 0, O that means none, or S that means single. The third letter represents sensing, response to sensing. It could be triggered, it could be inhibited, or it could be dual response. Like in DDD, there is a atrial triggered ventricular inhibited response, or it could be O, that means none. So the pacemaker, if it is programmed to O, that means it will not operate at all. Now on the right side, and then fourth letter is rate modulation, whether it is present or not. And the fifth letter indicates multi-site pacing, whether in the ventricle or in the atrium or dual or none. Now on the right side, we have common pacing modes. So VVI is a very commonly used pacemaker still in our countries, and which means that VVI means V, first letter means ventricle paced, second letter ventricle sensed, and third is inhibited. So it's in demand mode. The fourth letter could be sometimes present, which is VVIR, which would mean that the pacemaker is rate responsive, which means it has got a sensor inside it, which can sense patient's activity and increase the heart rate accordingly. And the second common mode is AAI or AIR. Then we have DDD or DDDR. We have VDD, where we pace only the ventricle. It cannot pace in the atrium. Sometimes we convert the pacemaker into a asynchronous mode, or we stop sensing, which is called VOO. That often is done when the patient is undergoing surgery and we don't want the pacemaker to sense at all, just provide pacing, because it should not get inhibited by the cautery. So then we often program it to VOO mode. And then we have DDI and DDIR, which are usually troubleshooting modes. I will discuss in the second talk in the troubleshooting. So some of the basic electrical concepts, let us not spend too much time here, but it's very important to understand what is cathode and what is anode. So cathode is the negatively charged electrode that is in touch with the myocardium. That's called cathode. And the other one is called anode. Anode can be a ring electrode in a bipolar lead, or it can be the pacemaker body itself, which can work as anode in a unipolar pacing system. And the conduction pathway basically means that the current will flow from the cathode, enter the heart muscle, and then come back to the anode, either the ring or the pacemaker body itself. So that completes the conduction tissue, which involves the body tissue as well. Now, a unipolar system, as I said, has only one electrode at the tip, which is cathode, and the lead has only one conductor, and the pacemaker body functions as the anode. So the electrical current starts in the pacemaker, goes through the lead into the heart, and comes back through the body into the pacemaker. So pacemaker body works as an anode. So the circuit is very large, and therefore any external stimulus, whether it is cell phone, whether it is a sparking going on, whether it is some muscular potential, they all have more chance of interfering with the pacemaker function if it is unipolar. On the other hand, the bipolar pacing system has both the leads very close to each other in the pacemaker lead itself. So it has a tip electrode, which is cathode, and it has a ring electrode, which is anode. So the current circuit is very small, and therefore the chance of the electrical circuit being disturbed by external stimuli, cell phone radiation or other sparking radiation or anything, whether muscular activity and all, is very less. So, and that's how the leads look like. So unipolar lead will have only one conductor, and the bipolar lead has two conductor coils. It's a coaxial design, which means coaxial means one inside the other. So we have the cathode connected to the inner coil, and we have the anode or ring electrode connected to the outer coil. Now, every pacing circuit has following characteristics. One is the voltage, current, and impedance. So voltage is the driving force of the electric current, which causes the electrons to move or electrical current to move. And higher the voltage, higher the current flow. So we all know that if we touch a battery cell, nothing happens to us. But when we touch, say, a car battery, which is more powerful, we may get a small shock. And when we touch the house electricity, it will give a bigger shock because it has higher voltage of 230 volts. And if we touch 11,000, then nobody can save us. So the voltage will drive the current flow. And this is the gradient which drives the current flow. It's measured in volts. And higher the voltage, more the current flow. The flow of current itself is measured in amperes. So which is the unit for current flow. It's measured in milliamperes in case of pacemakers and represented by the letter I. And impedance is the opposition to the current flow, and it is measured in ohms. So it's very simple. And then there is the Ohm's law, which I will describe in very brief, which means that the current flow is directly proportional to the voltage. Higher the voltage, higher the current flow. And it is inversely proportional to the resistance. So that is Ohm's law. Now, this hydraulic comparison is very useful in describing the impact of voltage on the current flow. Now you see this tank, this blue color is a tank of water, and it is lying horizontal here, and it has, say, about 10,000 or say 100,000 gallons of water, and there is certain amount of flow. Now what happens if you make this tank upright? So if you convert it to upright, you are increasing the height of the tank of water head, and suddenly the water flow will increase. So that is what happens when we increase the voltage. This is like 1 volt and this is like 5 volt. So 5 volt will drive much more current. So that's how it happens. And if we increase the voltage, the current flow will increase. Similarly, in case of the leads, we can visualize the leads like water pipes. So with a normal open intact water pipe, there may be certain flow of water. But if we open the tube from the side, there may be more leakage of water. So some flow may decrease to the tip. And of course, the wastage of water will be increased. So the same thing happens in the pacemaker system. If the insulation is broken on the lead, there may be leakage of current from the sides of the lead, which would go in the body, not produce any effect usually. Sometimes it may stimulate the muscle, may cause twitching. So it may stimulate the pectoral muscles and cause twitching, but the flow may be maintained or decreased slightly, but the battery will drain very fast. Lastly, what happens if you tie a knot in the water pipe? There will be very less water. Similarly, what happens in the pacing lead, if there is a fracture, then the current flow decreases significantly, and the impedance, that is the resistance, will go up. So that's how we can give a hydraulic comparison or analogy to the electrical circuit. Now, lead impedance has a very important impact on the battery longevity. And if the impedance becomes low for whatever reason, usually it is because of erosion of the insulation, then the battery drain is very fast. So as manufacturers used to give about 300 to 400 ohms impedance in the lead, but now they're building leads with higher impedance. You see, these impedances built into the leads by the manufacturer. Normally, if you take an electrical wire, even if you take a 15-meter wire of copper or any good conductor, it will have an impedance of less than 5 ohms. So it is built into the leads. So there is a tendency from the manufacturers to produce higher impedance leads, which then don't allow too much of electric current wastage. So usually now we are seeing the electrical impedance of 800 to 1000 from the newly manufactured leads. And sometimes when there is so this is what I was talking, if there is an insulation break, then the resistance will decrease and there will be more wastage. But sometimes there may be a lead wire fracture, as we can see here. So that will increase the resistance and will be very less. And whenever we see that there's a rise in impedance, we should immediately suspect that patient may be developing fracture of the lead, and we should change the lead. So that is more dangerous. A fall in impedance is less dangerous because that leads to only wastage of current flow. And often we do not do anything because at the most it will lead to some shortening of the longevity of pacemaker, and we can change the pacemaker at that point. So why increase the number of procedures? But if the impedance is high, then that means patient may be unsafe because the pacing may stop suddenly, and then there is a reason for immediate intervention in the form of replacement of the lead. Now coming to pacing threshold. Now every pacemaker stimulus has two important attributes. One is the amplitude, which is measured in volts, and second is the pulse width, which is the duration of the pulse, which is measured in milliseconds, and usually 0.4 to 0.5 milliseconds is what is kept. And as far as as far as the amplitude is concerned, usually we keep around 2 to 3 volts. All modern pacemakers have what we call auto capture threshold test. So pacemaker can automatically perform tests to find the right amount of voltage to be programmed that saves battery significantly. So that's how it is. So that threshold test is performed like this, that we keep on decreasing the pacemaker voltage output. So here you can see that it's 1.25 volts, which is capturing. Then we decrease it to 1 volt, which also captures. Then we decrease it to 0.75 volt, which also captures. Then we decrease it to 0.5 volt, that loses capture. So it's not capturing. So the threshold is the last captured voltage. So in this example, patient has a pacing threshold of 0.75 volts. So we usually program it twice the captured voltage if we are doing manual programming. But in case of automatic systems, it can save battery significantly. Now, so that is we have already discussed that it is the minimum output necessary to capture the myocardium. And pulse width is, as I said, it is measured in milliseconds. Usually we keep it around 0.4 or 0.5, or it can be changed depending on the requirement. And then there is a thing called strength duration curve. So if you see on the right side, we have the strength duration curve. In the y-axis, we have the threshold here. So we have 1 volt, 2 volt, 3 volt, 4 volt, 5 volt. On the horizontal axis, we have the pulse width. So every stimulus has to have certain pulse width and the pulse width and the voltage. So all the impulses which fall above this curve will basically capture. And there are two important points that we can derive from the strength duration curve, which is one is the Rio base, which is the lowest voltage. So this is the lowest voltage that will capture. Even if you keep on increasing the pulse width to infinity, it will not change. So that is called Rio base. And chronaxy is the lowest pulse captures the myocardium at an amplitude twice the Rio base. So this is the Rio base level, 1.2 in this case, 2.4 becomes the chronaxy is the minimum pulse width that will capture at 2.5 volts. So these are the two important figures. And as I've already discussed that pacing threshold has a very important impact on pacemaker longevity. So we must try to have a good threshold at the time of implantation, and then we program the output properly so that the patient gets maximum service from the pacemaker. And all these factors, they basically impact the battery life, lead impedance, amplitude and pulse width setting, the percentage pace versus intrinsic events, and of course the rate responsive mode, whether it is programmed on or not. So sometimes it happens that when the patient doesn't want frequent, pacemaker changes, we often program the rate slower and we program the rate responsive mode a bit muted so that patient doesn't consume much battery and it lasts very long. Now, when we implant the pacemaker, the pacing lead undergoes some maturation, and at the time of implantation, there may be some injury in the myocardium, and which leads to fibrous calf formation. In some patients, this fibrous calf may be very prominent, and that can cause exit block here. So the threshold can rise, and that can become a problem for those patients. So now almost all pacemaker leads, they are steroid eluting. That is, they have a steroid pocket inside the tip, which keeps on releasing steroid, usually dexamethasone, and which minimizes the amount of fibrosis. Even screw-in leads, they have a silicone rubber reservoir which contains steroid and which keeps on releasing, and that improves the overall pacemaker lead maturation. So this used to be the situation about 25, 30 years back, that patients after implantation, we find very good threshold, and after 1 week, 2 weeks, 3 weeks, often the threshold will rise to 2 volt, 3 volt, and then it will start fall and settle at a high rate of around between 1 and 2 was considered a very good threshold. But now with the steroid eluting, it has become almost flat curve, and the patients have very good pacemaker threshold throughout. MR conditional leads and pacemakers which have slightly modified hardware. So as we can see in this particular example, this is from different pacemaker manufacturers have different solutions here. So what we can see here is that in this lead we have, this is the older lead which has a 4-wire coil, and the MRI lead has a 2-wire coil, and the from other manufacturer, Boston, it has only 1 wire, and then they also place these inductor filters, so there may be PTFE filter here between the 2 coils. which further limits the radiation. So a lot of technological advancements have taken place, the lead manufacturing, which are very helpful now, which have produced MR compatible leads. So that was about the pacemaker technology and construction. Now coming to the functionality, that is sensing. Now sensing is the ability of pacemaker to sense electrical signals when natural depolarization is occurring. And we know that all pacemakers, they work in demand mode. That means they can sense patient's activity and inhibit themselves from pacing. So that's very important. And this is another important aspect of intracardiac electrograms. Some of you may be exposed to electrophysiology, but most students are not always exposed to electrophysiology and intracardiac electrograms. So this is the difference between intracardiac and surface ECG. You can see how the surface ECG looks like. That's a typical normal QRS, but the intracardiac electrograms are somewhat different. And the pacemaker senses only the intracardiac electrogram. Now, if the pacemaker does not sense in intrinsic electrogram, what will happen? And this is what we see is that the first beat is paced. There is a pacemaker spike producing a paced QRS. Second is also paced QRS. Third one was a spontaneous QRS, but not sensed. Now, this may have been in the refractory period, so it doesn't matter. Sometimes after any sensed or paced event, there is a period which we call refractory period where the pacemaker stops sensing. So this may be in the refractory period, but it's obviously not sensed. And then the next one is again not sensed, and the pacemaker gives a spike. So pacemaker is not sensing. So this is called undersensing. On the other hand, there may be a thing called oversensing. So in this case, what is happening is that the pacemaker is pacing. The pacemaker is programmed to VVI 60, which means the pacemaker should be sensing for 1 second and then give a pulse. But here it is sensing, say, 1, 2, 3, 4, 5. So pacemaker should have given a spike somewhere here, but has not given. So even though there is no activity present, so that is something oversensing because something else is sensed from outside. You can see in the marker channel that there is some extraneous sensing. So the pacemaker is oversensing and getting inhibited when it should not have inhibited. The way we program sensitivity is in millivolts again. So we have certain sensitivity, and higher the programmed value, lower the sensitivity. So if we, for example, this is the intracardiac electrogram, and we have say P wave here, we have the QRS complex, and we have T wave. So if we keep a high sensitivity, which means a lower value of say 1.25, then a lot of electrograms can be sensed. If we keep a somewhat lower sensitivity, so 2.5 is considered lower sensitivity, because now only electrograms which are very tall can be sensed. So it has become lower. If we keep even lower sensitivity, which means a higher value of 5 millivolts, then nothing may be sensed in this example. So 0.5, then everything TV may get sense. So we have to keep an optimum sensitivity by sensing, which is very small circuit, so I may not be affecting it much. Now, another aspect is refractory period, which I briefly alluded to. So after every sensed and paced event, the pacemaker has what we call refractory period, in which there will not be any sensing. Because pacemaker should not keep on sensing repeated signals, it will get inhibited otherwise. So usually about 300 to 350 is what we call refractory period, in which there is no sensing. And then there is a alert window. So after this refractory period, pacemaker goes into sensing mode and is looking for the impulse, so that whenever there is an impulse, it will automatically sense it. There are so many other pacemaker intervals which will take a lot of time to discuss, about 45 minutes or so. So I will skip them in this talk, and then we will move on to the indications and choice of pacemaker. So pacemaker battery typically is lithium iodide battery. Now there are some other compounds, vanadium, etc., which are along with lithium. So, and they usually have a volt beginning of life value of 2.8 volts. Some pacemakers are coming with 3.2 volts also, and they contain certain amount of battery capacity, which is utilized during the life of the pacemaker. And typically the pacemakers last now about 10 to 15 years. They are quite reliable. It's very rare to have a premature battery failure. They have a very good volumetric energy density. They don't usually do much self-discharge, and they have very high hermeticity, which means that there is no gas generation during the operation. So the pacemakers are absolutely safe, but rarely there have been situations where there have been some leakage from the battery and consequently from the pacemaker as well. Now, usually what happens is that this battery voltage is maintained for a very long time, around the same value of 2.8. And towards the end, this is what happens, that pacemakers undergo battery depletion. And usually there are 2 points in that journey. One is called ERI, which is elective replacement indicator. And that is the time when we want to replace the pacemaker. And second point is EOL, that is end of life, when the pacemaker will stop functioning. So we don't want the pacemaker to go to EOL. And that's why it's very important to have a regular follow-up of pacemaker battery. And whenever the pacemaker reaches ERI, we must change it. Usually there is a gap of 3 to 6 months between the two. So there is enough time for pacemaker to be detected within the ERI, and then we can change the battery. Coming to the indications, usually there are 2 indications of pacemaker implantation. One, of course, is the 6-ANA syndrome, when the pulse rate, when the sinus node is diseased and it is not able to generate enough heart rate, which usually is 60 to 100. But in these patients, they may be bradycardia. The heart rate may hover around 40, 45, 30, or there may be long pauses. And as we all know that the pauses more than 3 seconds are significant. Some patients have what we call chronotropic incompetence as the main problem, where the resting heart rate may be okay, but it doesn't rise during activity, and the patients have severe symptoms because of that. So these are usual manifestations of 6-ANA syndrome. And I will again, because I think we are running short of time now, so I will not go into too much of details of each indication, but I would like to emphasize on one thing. These everybody can read. But important thing in 6-ANA syndrome is that there is no heart rate at which we will advise pacemaker if the patient is asymptomatic. So if a patient of 6-ANA syndrome comes to you with a heart rate of 32 or 35, which has been incidentally detected on the Holter or on the ECG, and the patient says, I'm absolutely fine. So we don't usually advise pacemaker to these patients. So symptoms are very important for implanting pacemaker in 6-ANA. And of course, not only the presence of symptom, but the correlation with the slow heart rate. So it is very important to document that the low heart rate actually, or the sinus pause actually correlates with the patient's symptom, and then only we should implant the pacemaker. And of course, in asymptomatic patients with 6-ANA, we should not implant a pacemaker. So that's a very, very important point. So symptom correlation is crucial, and usually we prefer a atrial based pacing in these patients. And when we implant a pacemaker, usually the question comes up whether we need a dual chamber pacemaker or a single chamber pacemaker is enough for 6-ANA syndrome patients. So many people believe that, and practice also, that they just implant a AEI pacemaker or a AIR pacemaker if AV conduction is intact. But what should be done in these patients is at the time of implantation, we should do atrial pacing. And if AV conduction is intact at the atrial pacing rate of 120, then we can implant a single chamber atrial pacemaker. And the PR interval should also be normal with little or no rise on atrial pacing. and the QRS complex should be narrow. That means patient should not have any bundle branch block. Then we can implant a single chamber AI pacemaker in 6-channel syndrome patients. Usually we should avoid a VVI pacemaker in these patients, either AI or a dual chamber pacemaker. And this is a classical algorithm for pacing mode in 6-channel syndrome. So if the patient has a normal left ventricle, then we can go for either DDD, or we can put a, if the patient has abnormal AV conduction, we obviously have to give a dual chamber pacemaker. If patient has good AV conduction, we can give a AIR pacemaker. If the patient has a depressed LV, that is 36% to 50%, then we prefer, we have to consider either septal pacing or his bundle pacing or CRT. And if the patient has a low ejection fraction, then we certainly have to consider a CRT or a septal pacing or his bundle pacing. And sometimes even ICD may be combined with that. In AV block, usually patient is more at risk, so we are more liberal in giving pacemaker. All patients with acquired complete heart block usually require a pacemaker unless absolutely asymptomatic. Usually they are congenital, and only patients who have first degree heart block, they are usually not indicated for pacemaker unless they have some muscular dystrophies which usually progress. So we can measure HV interval in these patients. If it is 70 millimeters or more, then we should certainly implant a pacemaker. Patients who have a permanent atrial fibrillation with symptomatic bradycardia, they need a pacemaker. And patients who otherwise have less degree of AV block, but they require beta blocker or calcium blockers as a necessary therapy, where we have to give bradycardic medicine, then of course we have to implant a pacemaker to these patients. And this is a detailed algorithm which I find very difficult because I think we are nearing the end of the talk. So, but anyway, we can, important thing is to look whether patient has first degree AV block. Then of course we usually don't consider pacemaker unless patient has intermittent complete heart block. If the patient has morbid type 1 AV block, then again pacemaker can be avoided in many patients if patient is asymptomatic. But if the patient has symptoms with second degree AV block, then we have to give. Or if the patient has a wide QRS along with second degree AV block, we have to give a pacemaker. And if patient has complete heart block or wide QRS 2:1 AV block, then we have to give a pacemaker. It's a class 1 indication. And whenever the patient has poor LV function, we must consider CRT in that patient. Now, this is the important category of patients who develop transient complete heart block after acute MI. Now, in these patients, we should hold on pacemaker decision for some time. We can keep the patient in CSTO for a longer time. If the AV block resolves within few days with no residual bundle branch block, then we can avoid pacemaker. If the patient has a bundle branch block, then we have to consider pacemaker, especially if the HV interval is more than 70 milliseconds in these patients. But patients who don't have any new bundle branch block, have only transient AV block, then it's a class 3 indication. We should totally avoid pacemaker in those patients. Now, sometimes patients come to us with syncope with the bundle branch block. So your patient may be having RBBB or LBBB or sometimes bifascicular block and comes with syncope. In those patients, we must do an EP study and look for HV interval. If it is more than 70, then we should give a pacemaker. If the patient has alternating bundle branch block, that is on some occasion he has RBBB, on other occasions if he has LBBB, then we have to give a pacemaker. And if LV function is poor, we have to consider CRT or CRTD. And some patients where the situation is not clear, we often, nowadays increasingly, we are implanting a loop recorder, that is implantable loop recorder. And that can clarify the diagnosis. Supposing the patient has a mild LV dysfunction and previous MI, EF may be around 40–45%, and comes with RBBB and has a syncope. Now we don't know whether AV block is the cause of syncope, or patient is having ventricular tachycardia, or it could be vasovagal. So a implantable loop recorder can resolve the issue. If the patient has a normal rhythm, it could be vasovagal. a patient, or if there is a VT or AV block, that can be documented on the implantable loop recorder at the time of syncope. Lastly, coming to the choice of pacing mode. Now, there are two important aspects which we take into account when we choose the type of pacemaker. One, of course, is the chronotropic incompetence. As we all know that the heart rate rises during various activities. It may be very low during sleep, around 50. And when you wake up, it increases. During walking, it further increases to around 80, 90, 100. And during running, it can further go up. And patients may have chronotropic incompetence when the response may be very slow, or it may be unstable, very ill-sustained response. So these patients, they require an activity sensor in their pacemaker. And the second aspect is to minimize the ventricular pacing. We have increasingly realized over last 2 decades or 3 decades that ventricular pacing is bad. So in pacemakers, we want to minimize the ventricular pacing. In CRT, we want to maximize ventricular pacing, but in pacemakers, we like to minimize the ventricular pacing because as we can see in the left panel, there are a lot of deleterious effects of right ventricular apical pacing, especially, which can lead to electrical and mechanical dysynchrony, which leads to structural remodeling of the left ventricle, LV dilatation. There may be LA dilatation, also LA fibrosis, which leads to atrial fibrillation and thromboembolism, and the LV progressive dilatation leads to heart failure. So this is not really good. So we want to minimize the ventricular pacing. That's why we like to do either a atrial pacemaker or a DDD with long AV delay. Or other strategies are to use algorithms which minimize the ventricular pacing, which are like AV hysteresis or surge hysteresis, or sometimes we have very specialized algorithms within the pacemakers. Like all manufacturers have certain algorithms like AI SafeR from Sorin Group, managed ventricular pacing from Medtronic, reverse mode switching from Rhythm IQ, and of course we have ventricular intrinsic preference from St. Jude Medical. So every manufacturer has algorithms to minimize the RV pacing. So these things are very important to determine. And that's a study from Gillis et al. Using the MVP mode. So we can see that in both 6NS as well as AV block, if you use these algorithms, the pacing percentage goes down, especially in 6NS, but also in AV block. The pacing percentage, the RV pacing percentage can be significantly reduced. Now, so the documented benefits of atrial-based pacing include lower incidence of atrial fibrillation. There would be lower risk of embolization and stroke, lower incidence of congestive heart failure, decreased atrial size, and low mortality and high survival rates. And if the AV synchrony is not present, if we just give a VVI pacemaker, then patients have atrial contraction against closed AV valve, which leads to progressive LA dilatation and atrial fibrillation. There will be ventricular contraction against open AV valves, which can lead to MR. So there is more MR, progressive atrial dilatation, and they often have pacemaker syndrome and congestive heart failure, and the quality of life is impaired in these patients. There have been many studies in patients to compare the single chamber versus dual chamber or AV synchrony, effect of AV synchrony. And this is the data from most of the studies, which indicates that in all-cause death, of course, there is no advantage. So the death is not prevented, but stroke embolism, there is a benefit, dual chamber pacemaker. There is a reduction of about 20%. Atrial fibrillation incidence, there is certain benefit. Heart failure hospitalization, no benefit. Exercise capacity, there is a benefit. So patients tolerate dual chamber pacemaker better. The quality of life is better. There is less chance of pacemaker syndrome. And quality of life variable results have been seen in different studies. And of course, complication-wise, there may be some more complication with dual chamber because the hardware is more. But by and large, we prefer dual chamber pacemaker. Now, this is a very simplistic algorithm. this is probably the last slide, and a very simplistic algorithm to choose the pacemaker. So as I said in the beginning, we can divide the pacemaker indication into two: saxena syndrome or AV block. If the patient has saxena syndrome or disease, then we see if it is intermittent, we can just choose TDDR plus, and of course we can choose AIR. And if we have persistent, then we have chronotrophic incompetence, then we have to give a rate response. And of course, if there is no chronotrophic incompetence, we can choose a DDD pacemaker, or we can choose single chamber AI pacemaker also in these patients. If the patient has a AV block, then of course we have to, if it is intermittent, we can choose a dual chamber pacemaker with automatic mode switch, and VVI pacemaker can also be given if patient has atrial fibrillation. If the patient has persistent complete heart block, then of course we have to choose a dual chamber pacemaker. VVIR should not be used as far as possible unless patient has atrial fibrillation. And of course, we must consider CRT if the patient has low ejection fraction. And some patients may also be considered for implantable defibrillator. So I think I will stop here. Thank you very much. There may be a lot of questions and I'll be happy to answer. This was a very, very long subject and I've tried to cover in 1 hour, but it's a very, very extensive subject. So I missed a lot of things, but maybe we can discuss some other time. But thank you very much for listening.
Thank you, sir. Thank you, sir. Excellent, elaborate, brilliant presentation, sir. Not only participants, here we saw 2,205 participants in the Zoom, 205.
Thank you.
Also in the Facebook Live, also lots of participants from the Bangladesh, India, Nepal, also Malaysia. Not only participants, we had the faculties also benefited your lecture. Professor Wadud, sir,
so much.
any comments, sir?
Yes, I have already been telling you, saxena sir is superb in telling the complex thing in very simple terms. So the whole thing is very palatable and appetizing and should attract the young people going into device therapy because of the complexity that's involved in the understanding of what's going on inside the heart, particularly the EGM-related complications, the things. Many people are not interested in that, but I do think, particularly in Bangladesh, we need more EP specialists and more people who are very capable of programming a pacemaker very well. And they are very capable of minimizing the pacemaker, getting the best out of it with lengthening the pacemaker life and doing the patient the best possible treatment that care we can give. Thank you, sir.
Thank you.
Mujumdar, sir. Sir. Professor Abdul, sir.
Okay. Not surprising that Dr. Anil has delivered the very nice presentations as usual, and it is very enjoying that the very basic things are elaborated for the purpose of the understanding. Then it is not only for the juniors or the beginners, also for the refreshers course for the senior cardiologists who are not dealing with the electrophysiology as usually. As myself is a clinical cardiologist, so we have to have some refreshers and the specialized subjects. The one thing you can include is the pacemaker follow-up. Follow-up of the pacemaker or troubleshooting of the pacemaker is a very important thing for the practicing cardiologist. They
so in the next talk, I will talk about the implantation procedure and follow-up and troubleshooting.
Right, that is important part because many cardiologists will not go to implant the pacemakers or choose the pacemaker. Rather, they have to follow up the pacemakers in the very far corners of the country. So anyway, I think that there is a program of this follow-up and the complications of the pacemaker, which will be delivered by him. Thank you very much, Dr. Anil Saxena, and the other faculty present here. I see Professor Jalaluddin sir is here. Assalamu alaikum, sir. Professor Jalaluddin sir. After a long
He-
time, he's my teacher, direct teacher. He's,
I
after
know.
long
Yeah, I've met so many times in Labed and also in Pulse also.
Yeah, yeah.
Yeah.
Assalamualaikum, sir.
Professor,
Assalamualaikum,
To you,
sir.
sir.
the teachers.
Thank you, Mohsin, and thank you, Wadud, for arranging such a good program. Thank you.
Thank you, sir. Professor Abdul Rahman, sir. Professor Abdul Rahman, sir.
Sir is here. Assalamualaikum, sir. Sir, unmute, please.
Professor Abdul Rahman, sir. Yeah.
Yes, thank you very much for adding me in this greatest webinar. So I must appreciate the Anil Saxena. Always I like the Anil Saxena. He knows it.
Thank you. Sir.
He's a very humble and he's a knowledgeable. That's very important for a teacher. And other thing is that I must to highlight his thing is that he always think of who are the participant. So he always select the topics, select the thing according to the participant. That's very important. It may not be very much suitable for seniors, but refreshment that Mohsin sir told me that the refreshment of the, that's very important. Number 3 is the time limitation. These are the, I think so, I must appreciate that we finish the talk within the time. Otherwise, the people become bored. Now, I will say that it is excellent lecture. I love it. I refresh it. I learn it. And as I know that Professor Jalaluddin sir, when I was his assistant professor, he was the only man who is doing the pacemaker in NICBD. And I know that every day he put 2 or 3 pacemaker, because at the time nobody is doing the pacemaker. Japo sir has the time, so it is my opportunity that at the time I have. I was the only assistant professor, and Mahawali sir was there. But sometimes Mahawali sir left the cath lab as usual. But I have to stay with him with a lot of radiation in the old lab. I must appreciate Professor Jalal. He is the initiator of intervention electrophysiology in Bangladesh. I will say that he's the initiator. And later Robic sir is coming up. And actually he select Atahar to send for electrophysiology in India, and under Anil Saxena and his team. So I must appreciate that, the Professor Jalal. I will never forget that. So I have many experience with him and in the old cath lab in NICBD. So I will say that he may be the, I will not say the pioneer, but he is the most experienced pacemaker implantation in my lifetime. I will say that. Regarding the electrophysiology, we have a very experienced electrophysiologist, but we have only 2 dedicated center. One is the government sector NICBD in the electrophysiology. Only these 2 dedicated electrophysiology unit. We need more. Regarding the one question is to me, to Anil Saxena, very simple question. AI pacemaker. So if in saxena syndrome, if I want to put the AI pacemaker in a single chamber, then we have to know what is the condition of the AV delay. Do you recommend that in all the time we have to go for electrophysiologic study before putting the AI pacemaker? This is one. Another question you raised the question that regarding the alternate bundle branch block, we have to also study the especially in LV dysfunction, alternate study of the electrophysiology of the study. We are blindly putting the stent. We are the cardiologist, basic cardiologist. We are putting the stent blindly. Suppose Sinclair syndrome, we are ignoring the AV conduction. We may put the AI pacemaker, but there is an interrelation, or we need to more collaborative work. Those we are the clinical doing the intervention pacemaker, but we need some support from the specialist, like what is available in our country, also from you people from the outside. What is your comment about that?
So I think very important questions regarding the AI choice of AI pacemaker. It can be done even without EP study. So if the patient has a normal PR interval and the QRS complex is narrow and normal, that means there is no conduction system disease in the ventricle. So these patients can be considered for AI pacemaker. And further, at the time of implantation, what we can do is that once we put the lead inside the atrium, and usually nowadays we take a active fixation lead only, so we can try atrial pacing first. And if we find that there is no severe prolongation of PR interval, or if the AV block does not appear up to the heart rate pacing rate of 120, then we can give a AI pacemaker. If we find that on atrial pacing patient develops AV block, so at the rate of 90 or 100, then we should try to convert to dual chamber. But of course, we have to decide beforehand because patients need to give consent and there may be some expense involved. So patients, they can be told either in advance that we will try to do a single chamber, but you may require a dual chamber. But on the ECG itself, if the QRS is narrow and PR is normal, then we can assume that AV node is good and we can give a single chamber pacemaker.
Thank you.
Thank you, sir. Was Atharli, sir? Yeah. Atharli, sir?
Yes.
He is my mentor. He is my trainer. About him, I experienced since long back from year 1999. That is, it is about more than 20 years experience about him. I have learned many lectures from him in many in home and abroad in India and some other countries, and I have all attended many of the procedures. I have attended many of the procedures with him. So about him, my experience is very, very, very long back. He is an outstanding teacher, really. I have got many things. My learning begins with him about the electrophysiology from the escorts. So, and today's lecture is exceptional about it because it is very difficult to say ABC about the pacemaker. I personally learned many things from him and hope that our participants will also learn from him. If you give me some, I have got some questions, but the participants are encouraged first. So really, I am very much happy to enjoy this lecture. This is a wonderful lecture.
Thank you so much. Thank you, Doctor.
Before any panelist, Dr. Arif, do you hear me?
So I'm hearing you, sir.
I like to talk with Dr. Anil Saxena. I am Dr. Sohrab-uz-Zaman.
Oh, Sohrab sir.
Hi, Dr. Sohrab. How are you?
हाँ sir, कैसे हो?
So nice. Thank you so much.
अच्छा सर, ये बताओ. I have to ask. In Medtronic, there is AIR to VV DDD. Okay, I can start my video. Okay.
Okay, see you, sir.
That's called MVP mode.
MVP mode. Sir, that is more. I think I used to put in case of saxena syndrome. I used to think of this line because in St. Jude's also they have got the same properties. They called it in intrinsic something intrinsic. They called it something. Inherent preference. Sir, don't you think that it is better? Don't you think that, sir, it is better to put that in case of
both are good. I like both of them. In fact, they have certain advantages of each, but by and large, there may be minor differences, but by and large, they both are good. In fact, Boston also have an algorithm, so they all are almost comparable.
But the thing is that not to put an AI pacemaker, but to put a DDD pacemaker.
You are right. Yes,
steps.
exactly.
Sir.
I
Yes, it is preferable.
Yeah.
I do it like this.
Definitely.
Another thing, especially the St. Jude's people, they are talking about that atrial fibrillation suppression.
Yes.
And in a DDD pacemaker, but I still today, even today, I used to put a VVI in case of atrial fibrillation. What is your opinion regarding it, sir?
Yeah, so if patient has a permanent atrial fibrillation, then there is no point trying to suppress it. But some patients may have very, infrequent paroxysmal atrial fibrillation. There it has been seen that if you put a pacemaker with AF algorithm, then they may have less atrial fibrillation subsequently. So it is, you have to see the degree of atrial fibrillation. If it is permanent, then of course we have to give a VVI only.
VVI. Thank you, sir.
Thank you, sir.
I'm in my opinion now, sir. I have to start. Please forgive me. Let me leave.
Please go ahead.
Sir, take care, sir. Take care, sir. Stay safe. Take care, sir. Dr. Arif?
Yes, sir. I'm listening, sir. Hello, sir. This is Dr. Arif.
For the
I
junior
just
colleagues,
added for
some
you.
lots of questions in chat box. Please.
I have one undergone training under you.
Of
Professor
course,
Abdul
yes,
sir
yes, I
sent me
remember you.
for
Thank you,
exposure
sir.
under your supervision.
Yeah.
Thank you,
Thank you
sir.
so much.
So there are lots of questions in the chat box, and you have also discussed already most of the questions. So I'm picking few questions so that it's helpful for ours. So
Yes,
after myocardial infarction, both in anterior MI and inferior MI, how long we should wait to implant permanent pacemaker, or how long we can put patient for temporary pacemaker, sir?
Very good question. So the approach is totally different. In inferior MI, in almost all cases, 99% it is a transient thing, and in most cases it will disappear within few days. In 95% up to within a week or so. In some patients, it may last 2 weeks, 3 weeks, but invariably it goes back to normal rhythm in inferior MI. So these patients very rarely will require a pacemaker. On the other hand, in anterior MI, usually if patient develops a new AV block, that means the MI is very extensive, and it is usually because of necrosis of the septum. And these patients, they as such have a bad prognosis, and usually the complete block less often disappears. So they end up requiring a pacemaker most often, because even if the AV block disappears, it is left with some residual bundle branch block. So patient may develop LBBB or RBBB, and if patient has acute MI with transient complete heart block and residual bundle branch block, then it's a indication for pacemaker. If we are in doubt, we can do a EP study and look at the HV interval. If it is more than 70, then we can put a pacemaker. Less than 70, we can avoid. If patient is not very sure and he really wants to be stratified.
Okay, thank you, sir. So in this sitting, which you prefer first, whether it's correction of the electrical abnormalities or correction of the coronary abnormalities?
So usually nowadays, whenever a patient presents with acute MI to any hospital with cath lab, usually angiography is done and the artery is open, and that helps in resolution of ischemia, especially in the peripheral zone. So there may be early resolution of the AV block also because of correction of the underlying blockage. So it is usually the first thing to be done.
Can I ask a supplementary question, Arif?
Yes,
Sure, sir. Sure, sir.
Yes, sir.
Saxena, sir?
Yes,
sir.
In case of the entry MI, right bundle branch block with the fascicular block, that is the bifascicular. Yes, sir. From bifascicular block with or without the AV nodal block, but sometimes there may be the first degree block, but there is no evidence of the second degree or complete heart block. What about this group of the patients, sir? There is no previous AV block, that is the second or third degree heart block, but maybe the first degree heart block, but the bifascicular block in case of the entry MI.
So if patient before MI ECG was normal, and after MI patient develops a bifascicular block, and there is no complete heart block, only bifascicular block,
right, sir.
Then I think we should check the HV interval. We should not implant pacemaker directly. If the patient has had a transient complete heart block and then residual bifascicular, then pacemaker should be implanted. Otherwise, we can check HV interval. If it is more than 70, then we should give it.
Thank you, sir.
Thank you, sir. There has been lots of questions related to atrial fibrillation. A patient with atrial fibrillation, which pacemaker mode you prefer and why?
Yeah. So if the patient has paroxysmal atrial fibrillation, that is, patient is mostly in sinus rhythm, but occasionally patient goes into atrial fibrillation, then we should put a conventional dual chamber pacemaker with the two algorithms. One algorithm is called mode switching, automatic mode switching, which means that when the patient has atrial fibrillation, the pacemaker will stop tracking the atrium and goes into a non-tracking mode. Otherwise, patient will have very fast heart beating. So to avoid that, pacemaker goes into AMS, that is automatic mode switch, and that mode is usually DDIR or DDD. So that is one aspect. And second is, it is preferable to have a AF suppression algorithm, which both St. Jude and Medtronic have in their pacemakers. So we can use a pacemaker with automatic mode switch and AF suppression algorithm if the patient is mostly in sinus rhythm and has occasional atrial fibrillation. If the patient is in complete like permanent atrial fibrillation, or most of the time patient has AFib, then atrium is not paceable. So there's no point giving a atrial lead in those patients. So there we can give a VVI pacemaker, or if the patient has AF with complete heart block and slow ventricular rate, then a CRT.
Okay, Arif, next question, Arif.
Sir, there's a question. Vishal Sesha wanted to know what is the clinical significance of rate responsiveness? Which sort of patient will be suitable for this rate responsiveness?
So patients usually who have sick sinus syndrome or chronotropic incompetence, they are the ones who require a rate response pacemaker. So nowadays, actually the price difference between DDD and DDR is not very high. So most of the patients end up having a DDD-R pacemaker. But even when we are giving single chamber pacemaker like AAI pacemaker or VVI pacemaker, it is better to give a pacemaker with rate response, because rate response is something very crucial. In fact, there was a study, large study, where VVIR was compared to dual chamber pacemaker, and they found that in the functional capacity there was very less difference. So rate response is very crucial. Only patients who have a very good AB node, very good sinus node, where the sinus node function is completely normal, or patients who develop MI after myocardial infarction or after surgery when the sinus node is completely normal, they can be given a DDD or VDD pacemaker. Other than that, usually a DDD-R pacemaker is indicated.
Thank you, sir.
Because nowadays, you know, this, let me give a supplementary point also, that this AIR, I mean, the rate response sensor is also now used for diagnostics purpose, that it collects patients' information about patients' activity and give us the activity trend of the pacemaker. So many patients, when they come back for follow-up, we can see their activity trend as to whether they have reduced activity in certain periods. So it correlates with their disease process, heart failure, etc. So it gives some additional information about their activity. So that is an additional advantage of giving a rate responsive pacemaker, that we can monitor patients' activity level.
Thank you, sir. There is now the multi-site pacing. What is the significance of multi-site pacing, and in which situation you prefer to implant this?
So multi-site pacing can be both atrial and ventricular. More often it is ventricular nowadays, which is called CRT. So CRT is a type of multi-site pacing that we put two leads in the ventricle, one in the ventricular, one in the right ventricle on the septum side, and one on through the coronary sinus to pace the lateral wall, free wall of the left ventricle. So that's a kind of multi-site pacing. In the atrium, it is not popularly done now, but it has been done in the past, and there have been many studies where it was found that if you do multi-site pacing in the atrium, then the atrial function is preserved better, and these patients do not usually develop atrial fibrillation so often. So it is multi-site is just a fact that we pace at different locations, at multiple locations within the ventricle or in the atrium.
Anil,
Thank
I
you,
have
sir.
been, Arif,
Sir.
can I ask? So,
Sure, sir.
Yeah, Prof. Suleiman.
Okay, I'm not the expert on this field. I believed on the AIR, but I don't believe on the VBIR. Okay, always I tell to my doctor that if you want to put the VBIR, because the price is not difference, there is no definite contraindication for dual chamber pacemaker, we should go for dual chamber pacemaker. There is now some situation is coming up that is his bundle pacemaker, then you can have a single chamber. Otherwise, VBI pacemaker should not be implanted in a patient. What is your opinion for that? Because VBIR,
can I supplement the question, sir?
Yeah,
Yes, sir.
There have been studies which have shown VBIR in some situation with normal LV function is better than DDD pacemaker. Is it right,
Yeah,
sir?
so that's what I was saying, that there was a large study which showed that
Yes.
as far as the functional capacity is concerned, VVIR was equal to DDD, dual chamber pacemaker, for from functional capacity point of view. But I agree with Professor Rahman that there are other disadvantages of that, especially in development of mitral regurgitation, in development of LV dysfunction, in development of atrial fibrillation and stroke. So there can be, and of course, pacemaker syndrome. So what he was trying to say is that either you go for VVI, or if you're going for upgrading to VVIR, then the difference between VVIR and the dual chamber pacemaker may be less. Price difference.
Exactly.
So especially if we have VDD pacemaker available, there was a time when VDD pacemakers were freely available, single lead VDD.
Yeah.
And the difference between VVIR cost and VDD pacemaker was very less. And we implanted a lot of VDD at that time because that will give advantage of AV synchrony also. So it's a very important point that we should try to preserve AV synchrony as far as possible.
Arif, can I ask? Can I ask one?
Almost, sir. Please, sir. Please, sir.
Thank you, sir, for brilliant presentation. I am Professor Amol from NICBD. I am not like Professor Abdul. I am not specialized in this field. We are interventionists. My question, previously, when we are in the student profile, we put a lot of VDD pacemaker in country like our status. This was a single lead dual chamber. What is the present situation of this mode, and which is the best still if it is used, in which indication we can still use it?
Yeah, so there was a phase about 20 years ago when for about 1 decade we used a lot of VDD pacemakers, but now the availability has decreased, probably because their use worldwide has decreased. There were some concerns about the atrial sensing, that it may not provide full atrial sensing or better atrial sensing. So since it is not available, we are not able to use them. But VDD mode is available in all the dual chamber pacemakers. So, but there is still a situation where we can use VDD, especially giving the patient cost advantage. But unfortunately, it is not available now.
Thank you, sir. Professor Mohammed Shahabuddin, sir. Professor Mohammed Shahabuddin, sir.
Thank you, Anil sir, for your for your nice and brilliant lecture. I completed this lecture in 7 hours, but you have completed in 1 hour. That is your beauty and that is your excellence, sir. Thank you very much, sir. We have learned a lot. I think many students learn a lot, including the panelists who are listening. There's be a refresher course also. Thank you very much, Mohsin and Dr. Abdul Wadud Chowdhury, for inviting me here. Thanks.
Sir, there's a question regarding anti-tachycardia function. So in which situation we use this and how it works, the anti-tachycardia function of pacemaker, sir?
Yeah, so anti-tachycardia pacing basically means that when the pacemaker detects a tachycardia, especially like atrial tachycardia, because ventricular tachycardia pacemaker cannot terminate, or it's not designed to terminate, because sometimes the basic principle is that most of the tachycardias are reentrant in origin. So there is a reentry circuit. And if you do overdrive pacing, you can break the tachycardia. Mostly you will break the tachycardia, but sometimes you can convert a tachycardia into fibrillation. So that can happen in the VT also, it can happen in the atrial tachycardia also. Now the pacemaker does not have a defibrillator function, so it cannot pace in the ventricle, because there may be a possibility it will produce ventricular fibrillation, in which case it will not be able to handle it. But atrial pacing is possible. Many pacemakers have automatic tachycardia pacing function, which can terminate atrial tachycardias. So that is built-in algorithm in many of the advanced pacemakers. It can function.
Sir.
So the basic thing is that when you pace overdrive, you can break the reentrant circuit and the tachycardia may terminate.
Thank you, sir. Tushar.
Dr. Devasrita Bhattacharya, you have a question?
Yeah, sir. Sir, wonderful presentation. As we always see from you. A industry-specific question, like in COVID situation, we all are virtually attached because we cannot see each other. And in this virtual situation, there are patients, those who are trying to avoid to go to hospitals. So if the patient already been implanted with a pacemaker or a ICD or a CRT device, they want to get connected with the physician. At the same time, they don't want to come to the hospital for infection perspective. So do you have any comment on remote monitoring in terms of your cases, your experience, or to share with the Bangladesh physicians, those who are senior physicians are all there, and your students? That is my question, sir.
I think that's a very important question. So care of patients from remote locations is very important, and many patients are not able to come. And nowadays, about 15 to 20% of our new pacemakers and ICDs, they're going back with remote monitoring equipment. So it has become very, very helpful. And during COVID, many patients have asked us that can we provide them remote monitoring, and companies are coming forward to send the remote monitoring equipment to their home. But supposing remote monitoring is not available for a pacemaker and the patient does not have that equipment, and we want to check the battery. So we can check it by just asking the patient to do a simple ECG. For example, a dual chamber pacemaker will convert to a single chamber pacemaker before the battery finishes completely. Pacemakers already have some built-in mechanisms by which they try to extend their own life as much as possible. So a dual chamber will convert to single chamber, and a single chamber will get a slow rate pacing. So the pacing rate will decrease on ECG from the programmed pacing rate. So we can come to know that the pacemaker battery has depleted. So in many ways we can check it. But remote monitoring definitely is the thing to do in today's time, not only with COVID, but even without COVID, because many complications which can be detected by remote monitoring will be detected only when the patient comes to the in-clinic follow-up. So usually patients come every 6 months. So for 6 months, they may be living with a situation like a high impedance, or which may compromise their not only quality of life, but sometimes it can be risky also. So if a patient has an impedance rise shortly after he left you, now patient will not come for another 6 months, and in between his lead may give way completely, and patient can have problems. So remote monitoring helps in those patients, in those situations.
Thank you, doctor.
The classic Jaman Kushar. Your question?
Yes, sir. Yes, sir. Saxena sir, good afternoon.
Good afternoon.
Sir, the question was initially started by Devastito. I was just asking, with many of the places of Bangladesh and India also, where there is not frequent advantage of the patients to go to the programmer to check. So what happens in many times, we find the patients coming after 6-7 years without any follow-up. So how an entry-level physician can understand the water depleted or not by seeing the ECG?
By seeing the ECG, which I said, I just replied that and question that if a patient has a dual chamber pacemaker, and when you see on ECG you find a single chamber pacing going on, you can assume that probably the pacemaker has switched from dual chamber to single chamber mode, so the battery has become weak. So that is one thing which happens. Second is the fall in the pacing rate. So in most of the pacemaker models, when the pacemaker battery diminishes or goes beyond ERI, then the pacing rate decreases. So by that you can make out. If there may be patients who are not totally dependent on pacemakers, so they will have their own rhythm, but the battery may be weak. So you can ask them to place a magnet over the pacemaker and take an ECG, if possible. So magnet rate can tell us. So every manufacturer has a certain pacing magnet rate, which will change when the battery becomes weak.
Yes, it is different in different. Thank you,
Khalid Mohsin, sir. Professor Khalid Mohsin, sir. Khalid Mohsin, sir.
Yeah. Good afternoon, Saxena sir.
Good afternoon.
Okay. In patients with sinus node disease with intact ventricular atrial conduction, they are prone to pacemaker syndrome. And in this group of patients, what mode of pacing is recommended in sinus node disease with intact VA conduction?
Yeah, so in patients who have sinus node disease with intact AV conduction, we like to give a atrial-based pacemaker. It should be either AI, AIR, or it should be dual chamber pacemaker. ventricular pacemaker, VVI pacemaker should not be given as far as possible because these patients don't do very well. They develop atrial fibrillation more often, LV dysfunction more often, mitral regurgitation, abnormal remodeling of the left ventricle. So it's not a very good thing to do. So either atrial based pacing with totally AI or AIR, or a dual chamber pacemaker, because about 1 to 2% per patients may develop AV block every year. So the incidence of AV block in 6-sinus syndrome patients is about 1 to 2% per year. And second, if we are giving them atrial pacemaker only, they should understand that they may develop AV block, and in which they will need an upgrade of the pacemaker.
Thank you, sir. Professor Jalaluddin, sir. Professor Mohammad Jalaluddin, sir.
First of all, I thank Dr. Abdul Rahman, who was my student, as well as later on he worked with me as assistant professor. And also Dr. Surabudjaman, he was also my student as well as my assistant professor. Later on, they got training in Sport Hospital under the guidance of Dr. Anil Saxena. So I express my gratitude to Dr. Anil Saxena to train them up.
Thank you,
so
sir.
Now Professor Ataharali and Dr. Surabudjaman, both of them are working here as EP specialist and implanting pacemaker, different types of pacemaker in the Bangladesh. And now they are doing very well. Now that's why I thank and express my gratitude to Dr. Anil Saxena. I met him several times in Levitt. So we met together and we felt very well at his presence in Levitt. Once he came to Impulse Hospital for a glimpse, but
yes,
we could not talk more at the time.
Yeah, came only to visit. Yeah, thank you.
Though Dr. Abdul Rahman was very much interested at that time in pacemaker with me, but later on he switched over to intervention and he's doing very well in coronary intervention. He's one of the leading interventionists in Bangladesh in coronary and angioplasty. So once again, I thank Dr. Anil Saxena for training our doctors in Bangladesh who are doing very well in EP studies and implanting the pacemakers. Thank you very much, Dr. Anil Saxena.
Thank you, sir. Thank you, sir.
And Dr. Shahjan Kabir, he's from Malaysia. He's the faculty of Malaysia faculty. Dr. Shahjan Kabir, do you have any questions? So,
thank you, sir, for it's my honor to be in this webinar as a panelist. And thank you, Anil Saxena, Doctor, for your very nice presentation.
Thank you.
I just want to ask regarding that, how can we reduce, by doing some prophylaxis, reduce the pacemaker-induced infection? How can we reduce? Is there any prophylaxis or anything else we can reduce the pacemaker-induced infection?
Yeah, of course we can. So there are many ways by which. So I have another talk next.
I think we'll be talking about that later. We need to have a more talk on that. We need more input on that.
That's a very long topic.
Very nice.
Sir,
we want a detailed advice from you on that.
Because,
Mohsin, can I have one question more?
Yeah, yes, sir.
Yes, of course.
Sir, this is the question what I got. Sometimes I got call from my colleagues. They ask to know that is what to do. There is the patients of the acute inferior MI, patients still on TPM, angiogram done or 4th or 5th or 6 days. This patient is still on the TPM. The right coronary shows either totally occluded or revascularization is not possible. They ask to know what to do. This is sometimes
if patient stays on temporary pacemaker beyond 5-6 days up to a week, we can wait. If patient has very slow rhythm, after that we have to implant a pacemaker. There is no doubt. Even though knowing that even majority of them will convert to normal sinus rhythm, may not require pacemaker long term. But if the patient is in complete heart block and requiring TPI, then we have to implant a pacemaker.
Okay, sir.
So it would be a rare patient of inferior MI, definitely.
Dr. Virat, do you hear me?
Yes, sir.
Dr. Virat, yeah, please
Yes,
put your question. Yeah.
Thank you, Anil, sir. It was a brilliant presentation. So I have one question. So occasionally what we see is we see patients who are taking drugs like beta blocker and presenting with complete heart block. So when they come with a complete outlook, we tend to attribute it to an offending agent like beta blockers or other drugs, and tend to withdraw it. So my question is, how do you know if that is the offending agent that is causing complete outblock, and how long should we wait after stopping the drug before deciding on taking the patient for permanent pacemaker? Sir?
I think very good question and practical question. Now, the answer is that we look at the dose of beta blocker the patient was taking. That is the first thing we look at. If the patient was taking up to 25 or 50 milligram, that usually that is not the cause. It may be aggravating factor, that is patient has a pre-existing conduction system disease, and even a small dose of beta blocker aggravated the AV block. So it is not offending agent as in that sense. The second thing that we must look at is the site of AV block. So if the patient has block occurring above the AV node or in the nodal region, we can wait also. The most important thing to look at is whether patient has any bundle branch block or not, and what is the QRS duration. If the QRS is normal without any bundle branch block, then we know that patient is in a safer situation. But if the patient came with complete heart block and after some time you stop beta blocker and the normal rhythm resumed, but the patient has the underlying conduction system disease manifest as bundle branch block or bifascicular block or LVVB, then I think it is better to put a pacemaker. And we also look at the need for beta blocker. There may be some patients where beta blocker therapy may be an essential component, like heart failure patients or ischemia patients. So we really would like to give beta blocker. So we should put a pacemaker and then continue with the medical therapy, necessary medical therapy.
Thank you, sir.
Thank you. Dr. Arif, any question in the chat box? Yeah.
I think most of the questions have been discussed in the lectures. So
Okay,
I think you can proceed, sir.
Professor Rajia Madam with us. Do you hear me, madam?
Unmute, madam.
Yeah, madam, unmute.
Madam, mic ta on karen, madam.
Yes.
Yeah.
Oh, fine.
Okay, madam. Yeah.
Thank you so much for including me.
Thank you, ma'am.
I met Dr. Anil Saxena about more than 20 years back. I don't know if you remember, in Egypt, I think.
Okay.
A very long time back.
Thank you so much.
And I enjoyed thoroughly your excellent lecture. It's a very good recapitulation.
Thank you.
I liked it. Anyway, welcome back here. And I've met you in Labed, I think, a couple of times.
Yes.
Thank you so much.
Thank you so much, ma'am.
Thank you, madam.
Thank you, ma'am.
I think we passed around 1 hour 45 minutes. Lots of discussion occurred. Thank you, sir, for your elaborate and
thank you, Dr. Mohsin.
I think palatable presentation, sir.
Thank you so much.
Our next class in I think 12 July next month.
Yes. Yes.
Okay. Wadud sir, your comment?
I think everybody really enjoyed it. And
thank you so much.
I'm very curious, sir, what you will be talking next. What will be your planning?
So the next talk, as we discussed, Dr. Mohsin, will be on pacemaker implantation and follow-up and troubleshooting.
Yeah. Okay. And as I was saying,
and I'll cover the infection control part also.
The infection control. That's
very important. Very important.
Giving importance to that. And regarding troubleshooting, I think we will need another classes how to optimize the pacing parameters, how to minimize the pacing. One thing is that in CRT, we want that the patient should be 100% paced, by the pace. In pacemaker, we want that the patient should have his own rhythm, his or her, as much as is possible. True. And the trick of doing that is to have good understanding of the programming. The next day, we're looking for that. We want to have a very good lecture from you on the implantation techniques, the problems that can occur in different situations, how we can overcome that, how can we avoid infections, and if that happens, what to do in there. And I really thank you from all of us, the audience. Thank you, sir.
Thank you, sir.
Thank you, sir.
Here we acknowledged about vascular center medical. Yeah.
Thank you so much.
Cardiac rhythm management. I would like to call Mr. Devasrita, please vote of thanks for the audience and participants.
Yes, sir. Thank you so much. Thank you very much. because Dr. Anil Saxena, the name whenever it comes entire Asia Pacific region, the first thing comes in participant mind is
I think
yeah, Chandra is also there.
Yeah.
Thank you so much, because any time Dr. Saxena's name come, the first thing comes on the other side people that the best teacher is available. So people gives their time and they really listen to you, sir. And from industry like Abbott's and you do always being pioneer for your students. Any of the student comes, many student goes from here to your place to learn, and we are really grateful to Dr. Mohsin and Dr. Wadud and IPDI that you have started such beautiful, and we really thankful to be a part of that, and we keep on continue doing it. So my heartfelt gratitude to all of you, those who are as a panelist, those who are as a faculty, or those who are as a attendee. So keep learning during this COVID situation, as the patient pressure is little bit less. So as many as possible that students should learn from you like teacher. So thank you very much from our end.
Thank you. Thank you.
Thank you. We have now specialists because we are mentally stressed because we lost our more than 62 doctors and our cardiologists. So we have so much stress condition continue the program. Thanks, Professor Saxena sir, for a brilliant presentation. Thank participants, more than 200 participants on Zoom and on the Facebook also. Thank Incepta Pharmaceuticals. Incepta doing lots of job last 1.5 months. Thanks, Incepta. IPDI launched the YouTube channel, so you can click on this lecture on the YouTube. Just type www.hello.health and scroll down. Click on the IPDI virtual classroom and enjoy the only Saxena class, including previous 16 class also. Thanks, Dr. Arifur Rahman Shojol, and
thank you, sir.
Sir Abdul Chaudhury sir, for your brilliant support to me. And our next class on Tuesday, Professor H.L. Rahman sir, he took class on the aortic degradation. Till then, I think stay safe, take care, and good afternoon. Stay safe. Thank you all.
Thank you, sir. Goodbye.
Thanks, Unil
Goodbye,
Saxena sir.
everybody.
Bye. Thank you.
Devashrita, thank you.
Thank you so much, sir.
Mohan, thank you.
Thank you. Bye, everybody. Thanks.
Bye.
Thank you. Thank you,
Thank
sir.
you, sir.
Thank you, Surabh sir.